Hello, and today we've been sent a case for an edentulous site number 12. And the note is, please evaluate this plan and give input. I plan on using classic guide due to the number of crowns, etc. that the patient has. Thank you. So first, let's go ahead and talk about the use of the classic guide here. And I would say that, listen, it's a great idea that we've recognized that there's a significant number of restorations here, and that a classic guide is the safest bet to be able to do this. With that being said, if this patient were to walk into my office, I would probably not necessarily lean on the classic guide, and the reason being is that I have these anterior teeth right here, tooth number 6, 7, 8, maybe 9, 10, and 11 for certain, that are all relatively natural teeth, so I could expect my CEREC data to get integrated. And also, if we take a look that you were able to integrate your CEREC data, and if we take a look at this at the axial view, you can see that our data has integrated quite nicely right here. See how closely that approximates the teeth here. So while a classic guide has been scanned for, it is a great safe bet. But knowing that we were able to get the CEREC data in, and it was quite accurate here, even on the contralateral side here, on the patient's right-hand side, this would be a great case to use for an OPTI guide to avoid having to mail anything in to CCAT. So your choices, since you did scan with a biplate, are quite good. But an ideal situation here would be the OptiGuide just from a time and workflow perspective. So, but great recognizing the number of restorations there. So next, let's take a closer look at our plan. So here is the plan as it was sent to me. It's site number 12. And the first thing I always like to do when I evaluate plans that have been sent to me is I like to go ahead and take a look at the design of the CEREC restoration. So here we can see, because again, a lot of our planning is based on the prosthetic crown down model, and here we can see that our crown seems to fit into the arch form pretty nicely. As we look at it right here, it's well designed. We look at it right here as well. Our margin is pretty accurate in terms of what we can expect the restoration to come out looking like. The only thing I would maybe say is that we're a little bit thin on the lingual, but even that looks pretty darn good there. So this is a good design so that we can accurately plan our implant placement. Now, let's go ahead and take a look. We've planned for a 3.5 by 13. My ideal sizing for a premolar is going to be 4 by 13, but we can see in this particular case the tooth size is small, and one of the things I like to use as my gauge for what size restoration I can put in, what size implant I can put in there, is my sleeve. Usually the sleeve will correspond quite nicely, and here you can see our sleeve is going to be hitting the adjacent teeth when we went to a 4.3. So a 3.5 sleeve fits in nicely. That's going to give us room to develop an emergence profile and so forth. So I would lean towards the 3.5 millimeter implant here. Now, overall, generally speaking, your plan is quite nice. There are a couple of areas that I would consider making some changes on. One is right here. This is quite close. Now, we do have the accuracy of guided surgery, but why take that risk right there? So if we had the ability to simply just move that implant over a little bit and maybe even tilt it there just a little bit, gives us a little bit more space. Now we can still do a screw retain restoration here, and if we're worried about if let's say, for example, we wanted to come out even more, and now we're questioning our ability to do screw retain, we could look at the Nobel angle screw channel restoration. It wouldn't allow you to mill it directly in the office, but it's an option to get screw retained on angled cases. But I think in this particular situation, I think we're going to be able to do a screw retained restoration quite nicely here and avoid that. So far there looks good. In evaluating it, excuse me, we can see that our sleeve is pretty well centered. So, you know, if anything, we might move that over just a hair like so. In fact, I would probably move it over a little bit this way, because when I do go through my 360 here, we're pushing the limits right here, and we got quite a bit of space over on this side. So I would definitely move this over um, this way, so it's a little bit more centered between the roots. And in doing that, now we've collided with our adjacent tooth here. So then I would just use my tilt feature and tilt. There we go. So now that takes care of the root spacing potential issue there. Again, it was very close, minor changes here. And then the last thing I see in this particular plan of concern for me is we'll go through the 360-degree view here. And when we go through the 360 view, I can see that this tooth had been extracted, and I don't know when it was extracted. My guess would be relatively recently. And you can see here on tooth number 14, there may be something going on with the palatal root right there. Just could be a non-healed area, a radiographically healed area. But my only concern comes right here. I'm not seeing my buccal plate completely go through there. So in this case, this wouldn't prevent me from doing the implant treatment. It would just make me be ready to possibly have to graft that area. In other words, there's a chance that this bone hasn't fully formed. There's still a dehiscence there, maybe even some granulation tissue has crept in there. So I would be prepared to go ahead and flap this area back here to make sure that's clean, add a little bit of graft material, just to verify that that area is completely clean. So as we go back through it, again, if we were just to look at it in this slice, it looks fantastic. All of that bone is right there. But when we go through here, as you can see, as we keep moving, right there it disappears. And this is as we go backwards in our slicing 360 here, right there. So if I make my implant disappear, we can see that right here is where I'm talking about. That plate is clearly visible right here, clearly visible right here, but then between there it looks like it does this sort of thing. And the more you look at it, the more you can see the original root form of that tooth. So my suggestion in this particular case would be to be ready to graft that area and just honestly lay a flap and see what's going on there. And then if we're going to graft that, we could add just a little bit of granules right there. So generally speaking, this case looks ready to go. In my office, relatively straightforward. The only caution areas I have are on that buccal plate, and then it's not, because of the bone formulation here, it's not perfectly in the central groove. But to get it perfectly in the central groove, we would really have to do something a little along these lines, and I definitely would not be comfortable with that. So thank you for submitting this. I hope you found that helpful.